Tiếp theo thì theo chương trình thì là một cái báo cáo của Phó Giáo sư Lê Chí Dũng, nhưng mà Phó Giáo sư Lê Chí Dũng thì bận buổi sáng nay chưa báo cáo được. Và ngược lại thì có một cái giáo sư đến từ Nhật Bản rất là nổi tiếng, đáng ra là báo cáo phiên buổi chiều, nhưng mà giáo sư buổi chiều thì cũng bận, cho nên là ban tổ chức có đề nghị là đổi cái báo cáo lên phiên này. Và trước khi giới thiệu thì tôi cũng xin có một chút bằng tiếng Việt để chưa cho Huy biết. Thực ra đây là một giáo sư rất là nổi tiếng ở Nhật Bản, và chúng tôi cũng có dịp gặp nhau ở một cái hội nghị giải phẫu bệnh kỹ thuật số với trí tuệ nhân tạo châu Á tháng trước. Lần này thì chúng ta rất may mắn được mời giáo sư đến đây để chia sẻ những kinh nghiệm mà tôi thấy trong cái tên này thì không phải là giải phẫu bệnh kỹ thuật số hay trí tuệ nhân tạo, mà là về bệnh phổi kẽ. Thì tôi cũng chưa biết là nội dung giáo sư sẽ báo cáo cái gì, nhưng mà tôi hy vọng là một cái báo cáo rất là hay. Maybe I have somewhat introduce about you. But I would like to introduce Professor Fukuoka from Japan. I think Professor Fukuoka is one of the very famous professors in Japan. He now is chair and professor and chair of Department of Pathology Informatics, Nagasaki University Graduate School of Biomedical Science. And I know that he is currently a president of the Japanese Association of Digital Pathology, and also president of Asian Society of Digital Pathology now. And we are very lucky today, very happy today to listen Professor Fukuoka presentation, but not about digital pathology. Oh, initial lung disease. Thank you very much, and please, Professor.
Thank you very much. I feel very honored and excited to have this opportunity. So my name is Junya. I usually talk about digital pathology and AI these days, but today's my talk. I get a request to talk about interstitial lung disease. So I actually talk mostly about pathology, but I implement a little bit of digital pathology in it. If you have a smartphone, you are welcome to scan everything, and there's some QR code embedded, and that will bring you to the digital slide. So you can bring those slides to your account. Okay, so let's see how I can do. Okay, so interesting. How I can have this? Yeah. So this image was created by the DALI. You know DALI, right? It's a generative AI. And I asked the AI to create the honeycomb endostage lung picture. It is not really accurate, but it's somewhat impressive. Today I talk about fibrosis in the lung pathology. How many of you are familiar with the interstitial lung disease pathology? Thank you so much. How many of you don't? If you don't know about interstitial lung disease, please raise hands. Oh, excellent, excellent. Then I can have something to you. So I talk about what's the fibrosis in the lung field, and I talk about distribution of the disease inside the lung field. These two are the most important part. And in the lung disease, interstitial lung disease pathology, recognition of UIP is the most important part, because that's very bad disease. Patient can die in 2-3 years. And very basic CT findings. If you don't know anything about the CT of the interstitial lung disease, that's very difficult. So I'll give you some of the very, very basic terminology, which is a key to understanding interstitial lung disease. And also I want to talk a little bit about the TBLE, because I doubt you have a cryobiopsy at this moment in this, how many of you are looking at a cryobiopsy? TBLB. transbronchial lung biopsy? No? You do, right? Yes, thank you so much. So, cryo biopsy is coming, but I will talk about TBLB for this time. So, these are the core things what pathologists must to understand. So, confirm whether the disease is a truly interstitial lung disease or not. That's very important. Interstitial lung disease is a kind of an inflammatory changes which you can be seen the similar part in any kind of thing. Like an infection shows similar picture in a lung, so you will be treated. And accurate to determine if the pattern is UIP or not, that's very, very important. You should always write down in your report that if this is UIP or not UIP. Because this is almost a cancer diagnosis to the patient. And list the differential diagnosis if you can in order of the likelihood. If you don't know much about it, you don't need to do it. But this is the one thing a little bit advanced. If you feel like this is HP, hypersensitive pneumonitis, you will list it. If you feel like this is more like a connective tissue disease, you list it with why you think the reasons why you think of it. And report findings that may respond to inflammatory, anti-inflammatory agent, such as acute lung injury, which is edematous change, OP, organizing pneumonia, or something like a DAD. Those are important to be treated by steroid, high-dose steroid, and anti-inflammatory agent. Or also inflammatory cell infiltration. This is also, some of the inflammatory, anti-inflammatory agents. And also identify findings suggestive of hypersensitive pneumonitis, which is granuloma, giant cell, and airway-centered inflammation. But this is a little bit hard, but I think you can recognize granuloma. So is there granuloma or not? It's very important. Just write that down. And participate in multidisciplinary team diagnosis as much as possible. Because pathology diagnosis is not the final diagnosis. Very important though. It's very important, very close to the final diagnosis. But we decide the final diagnosis with pulmonologists, radiologists, and then the pulmonologist will make a final call what this is. So I talk about those four. First, let's move on to the fibrosis in the lung. So fibrosis is a very broad term, but all organ has different kind of definition. It's not definition, but different way of use. So there are three types of fibrosis inside the lung. First one is dense collagen fibrosis. Second one is fibroelastosis by collapse. And the third one is a young fibroplasia. So I'll show one by one. Oops. So this one is a dense collagenous fibrosis. This is H&E, and this is elastic staining. We use elastic Van Giesen staining quite often, and I would recommend you to use this staining for the interstitial lung disease, because this will highlight black color as an elastic fiber, red color as a chronic collagen, and the smooth muscle as a yellow. And fibroelastosis, this is not really a fibrosis, it's just a collapse. Because the basic lung has a lot of those elastic fiber, that's why we are moving, right? It's like a rubber band. And when it collapses, it shows like those accumulation of the elastic fiber. This is also called fibrosis, but it's not really fibrosis. Third one is a young fibroplasia. This is more like a proliferation of a fibroblast along with a little bit of a collagen and many edema. So that's why it looks a little bit bluish. You see empty spaces, which is corresponding to the water-rich conditions. And in the elastic Van Giesen, it doesn't contain any elastic fiber in a collagen in those younger fibroplasia. So this one, why this is important? Because this is not treatable. This is also not treatable, but the cause is different. But this is treatable. Okay, this can go away. So very, very important. The treatment is different. So schematically, I will repeat the same thing. This is a cartoon, how the normal lung looks like. And when it has a dense collagen fibrosis, completely broken down the basic structure, and you see a lot of those collagens. And, oops, oh, come on, very difficult to move. Oh yeah, so this is fibroplasia. It just shows cracks, and there's no collagen fibers. And the third one is there's no breakdown of the structure, but you see a lot of those fibroblasts, edema and stuff inside the airspace. This is treatable. Very important. Second one is a distribution of the disease inside the lobule. What we are making a diagnosis based on is this distribution. Is there fibrosis and where the disease roots are located? Okay. Very difficult. So, okay, somehow my cartoon doesn't work very well, but fine. So this is a cartoon of the lung primary lobule. Okay, so we have airway and we have artery. This orange is a lymphatic route. This blue is a vein. Okay, so those pale yellow is an airspace. And where air comes is here, right? And when you inhale something, most of the inhaled stuff will be exhaled. But you cannot do completely because you cannot push everything into. There's some space left. So there are several things left. That's why when you have a speak to the smoker, they speak like a smoke with a smoking smell, right? I used to smoke, so I know what that is, but not these days. But anyhow, so it just stayed there for a long time. So the lung disease are mostly explained by the location because of these functions. So question, where do lesions develop? First, if the lesion comes from the blood, such as drug, such as immune disease like autoantibody connective tissue disease, when blood is a cause and inhalation cause and disease associated with lymphatics, so those are the conditions. First, when blood is, so my somehow interesting. Some people change my the animation, but when causes are coming from the blood, it is very natural to understand, right? Easy to understand that this distribute to the capillary diffusely. So when you have like a drug injury or connective tissue disease associated injury, disease comes as a very, very diffuse because it harms the capillary level. When inhalation cause comes, stay with the blood. So when disease comes diffusely, it affects like that. And then it progresses to honeycomb lung. So when you biopsy very much advanced disease, very difficult to distinguish from the honeycomb lung from the UIP or honeycomb lung from other things. So do not really make a biopsy from the end stage area. Transition area is the best place to take a biopsy. So what is the most important condition of diffuse distributed disease is NSIB. So this is like, let's say, you can still see the structure of the lung, but the most of the lung structure are kind of showing a thickened stroma with by fibrosis. Although levels of fibrosis severe here, weaker here, but everything is affected. That's diffuse disease. So this is a pathology of non-specific interstitial pneumonia, NSIB. So this is also NSIB, and although you see some difference of the lesions here, a little bit more, strongly affected. Here's weak, but if you look carefully, all of the area shows abnormality, although the levels are different. That's very important. So diffuse come diffusely. That's the key. of the diffuse disease. Why this is important? Because those patients live longer. And if you want to bring this slide, this is a slide, and okay, let's see. Where's no? So I have a slide. That looks like there's no internet connection in this computer, so fine. Okay. Yeah. One more time? Okay. Yeah, I asked the internet connection. So here's an embedded link. Take you to the digital slide, and which is not possible? 1 minute. Okay. Oh yeah, here. Okay, so the second screen, duplicate, okay, whatever. Okay, it's not me who's moving. Oh, yeah, here. So if you scan the QR code, you see this, right, in your smartphone. So close this tab, it shows something. This is the scleroderma associated interstitial disease. So this is the typical NSIB. Remember, if you look at some levels of the disease, there are some, accentuation in somewhere. So if you concentrate this area, this looks like UIP, right? There is some honeycomb cyst. So when you just focus on here, this looks like a UIP. This happens quite frequently. But most of the area, you see abnormality, and the basic lung structure is preserved. And this is a typical fibrotic NSIB. Okay, let's move on back to, I want to go back to the, okay. Yeah, thank you so much. So, if inhalation is the cause, how does it develop? It develops like here. So airway center location, very important. But remember, this is the main area, but if you can, inhalation, dust and everything was cleaned out by the lymphatic route. So you see a little bit of abnormality around here. Although main diseases are located around the airway, there are several things around the lymphatic route. That's also another important thing. So this is the inhalation cause. So disease associated to lymphatic route is like this. So this is a channel when the dust and everything, infectious flows, everything are cleaned out by the lymphatics. And what is the most important thing is that sarcoidosis. So if you want to bring the digital image of sarcoidosis, okay, thank you so much. No, you don't need to do it. This doesn't have a QR code. Okay, can you go back to it? Maybe I should use my own computer then. Okay, yeah. So this is the link. So here you see all of those nodules along the lymphatic route. Here, this is a typical area near the vessel, and by subchoroidal area where you see some lymphatic tissues, and also where you see a lot of the carbon dust. This is the area of the lymphatics where dust are accumulating. So it's usually around the veins and also the arteries. See those veins? Along the veins, you see all of those nodules. So this is the distribution on the lymphatics. And most representative disease is a sarcoidosis or lymphoma. Can you go back to that? Thank you so much. I give a lot of assignment for you. Sorry about it. Okay. Yeah, I know. I invited. No, down there. Go down. Here. No, I can move. Here. Okay, let's go here. Okay. So important thing is the UIP. Very important. If you understand the UIP, then all of the interstitial disease, half of the disease your job was done. UIP, how it develops, coming from here, very edge. So it comes from the peripheral zone of the lung, and it it also associated with the crabs. So this is UIP is a mixture of the destruction and the crabs. Remember, so it break all of those areas, and then in the middle, because they cannot move it because of the dense fibrosis, and it shows crabs. So it is a mixture of the crabs and the breaking of the breaking fibrosis, and finally ended up to have honeycomb cells. So this is UIP. So when you have this fibrosis, it is coming from the edges, from the subchoroidal zone, and eating little by little to go into the center. That's the UIP. So interesting. So if you look at here, it shows the transition from the dense fibrosis to the normal lung. In between, you see a little bit of blood and those areas, proliferation of the fibroblast, which is called fibroblastic focus. So this is active, subacute lesions eating normal lung little by little. So, but if you see a lot of those, which means this disease is very active. Okay? And where the UIP regions develop is like this area, subchoroidal zone, or around the bronchovascular bundle. So these are the zones around the veins. So these are the zones the UIP develop. Remember. So if you see all the lungs are involved equally, you have to be careful. Two things: is this NSIP or just end-stage honeycomb lung? If this is end-stage honeycomb lung, that can be anything. So this is a typical UIP. You see a diseases around the subchoroidal zone or around those bronchovascular bundles. So this is the typical distributions. Another UIP. And this is a slide. I don't have a time. You don't need to go. So I just give you the slides, and you can just look at the UIP slides in your home, and then and also your smartphone have a link address in the top. You can just copy it to send it to your email. Then you can see the exact same slide on your computer. Okay. So if you don't take a picture, you can just get those images. So why UIP is so important? Because when you see the UIP, and UIP can be seen many different causes: rheumatoid arthritis, hypersensitive pneumonitis, many causes can produce UIP. But if you don't see any background cause, it is called IPF. And disease of the IPF shows very poor prognosis compared to the others. As I said, in like 2-3 years, most of the patients get died. So it is worse than lung cancer. Very short, I want to show you what you should know about the CT in ILD. So these are all different, the features. Maybe you can just take a picture of this. And this is small nodules, nodular regions, and some nodules are cohesive. This is sarcoid, coming from sarcoid, all of these nodules. And this is called the mosaic pattern. See those, this is very black, but this is quite whitish. And here in between, those 3 different density is called 3 density patterns, which is very common for the hypersensitive pneumonitis. This is a very important mosaic pattern or 3 density patterns, very important. Next one is a reticulation. All of those lines. Those are the reticulation, very common for the UIP or NSIP, but most importantly UIP. And this one, last one, is a lot of those cysts, surrounded by some whitish, dense fibers, is called honeycomb. So those are very important terminology. Another one here is just a gray zone, gray area is called ground glass changes. And sometimes reticulation and ground glass makes quite an overlapping, so it's kind of difficult. But if you see it's gray, you can tell that this is ground glass. And which is very typically seen in NSIP and hypersensitive pneumonitis. Consolidation is more like a whitish, very completely white area, similar to those veins and everything. And if you see those rings, this is called reverse halo, very typical for the organizing pneumonia, OP. So if you see those consolidation, you consider OP or PPAP or DAD. So consolidation is the key. Another thing, sometimes consolidation can be those nodular, which is called nodular consolidations. This is more like a tumor or infection or still OP. Okay, last one is those, a black area, cystic area, which is called hypoattenuation, which is mostly emphysema. Okay? Last things, sorry, over time, but just 1 minute, is about TBLB in the lung. So most important thing is that you cannot tell much about interstitial lung disease by TBLB, but something you can call, like OP, you can make a diagnosis. CAP, you can make a diagnosis, alveolar proteinosis. Sarcoidosis, okay. UIP, maybe, may not be careful. LAM, maybe, may not be if it's included. So those NSIP, DIP, never call, okay? Although if you think this is pretty much convincing, never call. This is very important. And this one, I will give you a question to you. So how do you think about this? What is the disease? How many of you think this is a disease? Thank you so much. How many of you think this is a normal lung? Okay, so I'll show you. This doesn't look like normal, right? This is a normal lung. Okay, those two looks very different, but these are completely same. Because TBLB would cross, because it just, by the pulsate biopsy, it shows, like let's say, then that you start to see these things are abnormal. But actually, this is a completely normal lung. Okay, very important. So TBLB, but important thing is that remember you do elastic one-Giscon staining. Elastic one-Giscon staining is very useful. And then start to look at those red area, okay? There is a red area, this looks like a fibrosis here. In the other area, you start to see those red area. There is a dense collagen around here. Very important. So if you look at dense areas, this is involved between, collagen and elastic fibers, indicating that this is a destructive fibrosis, and this is actually indicating UIP. You can bring these slides to the back. I'm sorry, I talked too long, and I'll stop here. And this is the last summary. You just can take a picture. Thank you so much.
Thank you very much, Professor. Could I ask you a question which may not be directly related to treatment? The current understanding of idiopathic alveolar fibrosis, are we any further in helping to identify why it's idiopathic? And secondly, is there any effective treatment?
Yes, very important. Thank you so much. Idiopathic means there is no identifiable cause, but there are many factors which is overlapping with this idiopathic. What I want to name grades on something that is a connective tissue disease, like a rheumatoid arthritis, can produce UIP. And what is the difference between the IPF, which is idiopathic, and the UIP in a rheumatoid arthritis patient? Very overlap disease. But basically, you see many inflammatory changes inside the lung, similar to what you see in the synovium. So that's what we consider UIP was coming from the inflammation caused by rheumatoid. So I think that what is happening is the same. It's a UIP. But what is caused to create this disease is different. Sometimes rheumatoid arthritis and hypersensitive pneumonitis can also create UIP. And they are all bad disease. They are killing disease. So for us, most important thing is identify UIP or not. And if this is idiopathic, that's a clinician's work. It's not our work. Clinicians said, oh, this is UIP, okay? But we don't see any cause. Then they will call this as IBM or idiopathic, a cryptogenic fibrosing, alveolitis, that's English term, But, IBM. But clinicians see rheumatoid arthritis, they call this as rheumatoid arthritis UIP. That's the thing. Second thing, the treatment, very important. Recently, this is a very hot topic. the hot area, because we have a lot of new disease, agent coming from. So this is an anti-fibrotic agent, which is not curing the fibrosis, but stop the process of the fibrosis. So the key is early detection. You have to make a diagnosis earlier and slow down the progression by the medicine, anti-fibrotic disease. But the difference is that all the inflammatory disease have to be treated by steroid and anti-inflammatory agent. But this is actually progressing, accelerating the fibrosis. So you cannot use that anti-inflammatory agent to UIP patient. So that's the difference.
Thank you very much. Thank you.
Thank you very much, Professor. Yeah, your presentation is the last presentation this morning, but I think it's very, very interesting topic. Problem now in Vietnam and also in my hospital is we have not enough sample, inadequate sample for analysis of the reason of the lung disease. So with your experience, what kind or what size of needle biopsy do you often use in your practice? And who does the biopsy? The clinical doctor or diagnostic imaging doctor perform the biopsy?
Thank you very much. Needle biopsy is dangerous because that would create a pneumothorax, which is sometimes lethal to the patient, those patients. So what they do is two ways. One is open lung biopsy or BATS biopsy, but that's decreasing. And what you will see in the future is a cryo biopsy. They put the cryo probe from the mouth and then just freeze the tissue and get 4 or 5 millimeter tissue. Why I'm saying this, is that probably you don't know the frequency of this disease. This is about half of the lung cancer. That's a lot, actually. How many lung cancer tissues you see is quite frequent, right? Then half of the patient, number of the patient of the interstitial lung disease, about half of the lung cancer. So, but why you don't get the biopsy now is because they don't make a diagnosis, and there was no treatment available, until now. But now we have anti-fibrotic agent, which is becoming cheaper, and many vendors are now looking into. You're gonna be surprised. Right now, phase 3 the study is already over 100 in this field. Unbelievable. So it's coming. So prepare for it.
Thank you very much. Okay.
Yeah, you are an expert, and you are also the AI, expert. Because yesterday we have and another introduced AI, so they have the virtual trichrome. And for interstitial lung disease, as you mentioned, the fibrosis pattern like that, what do you think the role of AI in this? Because the IID is a multidiscipline, not just by pathology. What do you think the role?
Thank you very much for asking. That's my task, actually. Yes, and we have a lot of AI of this disease, actually. We published already one in modern pathology, but we have several. Multimodal for the CT. We also developed a CT AI as well. So because this area is quite difficult to reproduce the diagnosis. I know that how poor the inter-observer variability agreement in this field is. So right now that we are creating those models for the BATS biopsy, also TVLV with molecular RNA sequencing, and also the cryo biopsy. So all of those AI are now, everybody's developing those AI. So you can probably use that to make a report in the future. I hope that's coming in a couple of years ahead.
I have a question, 2 questions actually. Number one is, do you use elastin stain routinely for all of the lung biopsy in your lab? And second question, not equal to the lungs, equal to the AI. So do you think like with the sarcoma, do you think the potential to develop the model to detect the particles in sarcoma because it's so difficult in that area?
Sure. So first thing is, you know what? Overnight, right? So my memory. First thing, the elastic stain, right? So elastic, yes. For the interstitial lung disease, not only interstitial lung disease, we do elastic staining for all lung cases, and it's not so that difficult. It's just the one additional staining an ordinary lab can do. I think I would strongly recommend do the elastic staining because lung pathology, especially with the TBLB, it's quite difficult to see where these things are, or which one is the vessel, which one is the lung. Very difficult to identify. But with elastic fiber, normal lung has elastic fibers, but abnormal thing doesn't. So you can distinguish normal versus abnormal by having that one, and also where you can identify airspace quite easily. So if you see something inside the airspace, you can identify something abnormality as well. So I would recommend to do elastic fiber staining for most of the lung tissues. And second one is of course AI for sarcoma. That's one of the another hot topics because sarcoma is strongly associated with a lot of those translocation genetic abnormalities, and many people are now doing developing the models to predict those molecular alterations. And the prediction rate so far is quite good. AUC is not the greatest. It's about as far as I know, it's around 0.7, later 7, or early 8, something like that. So it's not really reaching to the strong publication, but I know many people are looking at it, and it's going to be coming soon. Yeah. Especially if you want to try that, especially now we have a foundation model. You know what the foundation model is? Yeah. So we already have several different foundation models available. Many of them you can use it freely for the research purpose. You cannot do business. You have to pay a lot of money for the business. But for the research, it's free. And it's all downloadable from the GitHub. So then go there and get all of those foundation model and try some to your models, because you don't have many cases, right, for those rare disease. You may have some, maybe hundreds of cases. But 200, 300 cases is not enough to create a good model for the prediction. But with the help of the foundation model, you can. So now is the time that you can create your own model in your own country, because our background is different, right? Japanese genetic background is different from the Western, and maybe you guys are different from ours too.
ก็bác sĩ Thạch còn một câu hỏi. Trước khi bác sĩ Thạch hỏi thì xin thông báo với toàn thể hội thảo là chúng ta đã qua 4 tiếng và 6 cái báo cáo rất là hay, rất là khó, rất là sâu. Và tôi nghĩ là mỗi một cái báo cáo như thế này phải tổ chức một cái hội thảo chuyên đề sâu thì chúng ta mới có thể thảo luận được hết. Sáng nay thì còn một cái báo cáo của giáo sư Anthony Roth thì chưa có thời gian để thảo luận. Nếu mà các quý đồng nghiệp có câu hỏi hay là có ý kiến gì thì cũng cho ý kiến 1-2 câu hỏi. Và xin mời bác sĩ.
I'm so sorry, time's up, but still have a question. Just that I come from National Children's Hospital, Hanoi, Vietnam. Interstitial lung disease is rare. However, I recognize that it's not really rare. Even in the hospital, sometimes we have a disease. But the patient is really severe. That's really important about this talk, your speech. I may have a question. The first one, how often do you have interstitial lung disease in your center? The other thing is, what's the difference between the adult and the children? And you have to deal with the adult patient or children's patient. Yeah. The third is, if I have a difficulty, is that okay? Or have a chance to contact with you for that situation.
Yeah, the children are actually different, but some disease, I think that about half of diseases are overlap. But of course, those are driven by genetics, right? So you have most of those UIP are driven by like telomere, and also some of the surfactant genes, and also something genes related to the senescence. So it's a little bit different, but the children, the surfactant genes are quite frequent, and some other genes I forgot which one was there, but you better do those genetic, the assessment. But unfortunately, there is not much good, treatment, for the children's ILD. So often the time you ended up to have transplantations, but only when the child has grown up to the large size. Otherwise, the lung is too small, right, to get this. So the children's ILD is so difficult to treat. Frequency of the ILD, because my place is the center of the whole ILD. So all the institutions send the tissue to me. So I see like 1,000 cases of the interstitial disease every year, probably more than that. But I think that from my own institutions, the number of the cases of those biopsy of ILD is about 50 to 100, maybe 50 to 200, something like that. So that's the kind of ordinary, the center who does the practice of the interstitial disease. And certain consultation, I'm happy to receive. Whenever, just contact me.